So, hello again. So, we are going to talk now about the transtibial prosthetist approach for the prosthetic assessment. So, we will share some information that I've learned, and I would like to thank my colleague, prosthetist Andrew Duncan, for his sharing these slides with me, as I've learned from him a lot, and he is based in Carlisle, in northern UK, and thanks him. And this prosthetist assessment and how we approach will help us to understand the idea behind it, and that is like really basic stuff. If you grasp the basic of prosthetics prosthetist assessment, the physiotherapist and the OT and all the other MDT will work together collaboratively. So my name is Anas Hassan again. I'm one of the SPR rehabilitation doctors in the UK. So I would like to share with you our typical assessment process, which is basically we starting by having this kind of form. And this kind of form will tell us that all the initial points that for the assessment for the patients, and it's really thing that we can look at from different aspects, and that will help. It's a form of communication between the prosthetist and the other teams and what they are thinking about. I will share this with everyone here. I will leave the link below, and you can get it, and you will look at it, and then you will understand what it is. Okay. So the first thing we like to ascertain is the amputation technique. So we need to make sure that we have the proper technique. Now, if we are doing as an elective vascular, that's a different scenario, but I will focus more on the more traumatic amputation, which is basically more is the majority of our Gazans cohort. And the first thing in that one is the vast majority of transtibial amputation will be more of traumatic and life-saving. It will not be a clean cut, and it will not be in a clean environment, and the wounds are more of like ballistic injuries wounds, and they will require different methods of flap and try to preserve what you can preserve. And sometimes if you found it that difficult, you need to go a level higher because you have more soft tissue. But we will start with the principles. Transtibial amputation, there are two types of amputation. There's the Burgess and there's the skew flap. So the Burgess is the long posterior flaps. Basically, there will be an amputation and they will take from the posterior aspect to the front, and it's basically like L shape of in the mid of the leg. It's the one on the left side, and that mediolateral scar in anterior distal aspect and large quantity of muscle retained. You will find that most of the calf muscle were coming from behind and coming to flap all the way at the front, covering the tibial shaft, tibial bone, and all of that tissue will be good for healing for the wound itself. The skew flap, it's another aspect, is anterolateral to posterior-medial. You can see how is the wound is coming from. That's was transverse. This one is more of like oblique one and more vertical. The medial scar in the distal aspect. And this kind of wound and amputation is a little bit favorable on the other type, but it depends on the surgeon. So the prosthetist, they will consider a few things: the size and the shape and the scar, and we need to make sure that these are in a good position. And we also see some amputation using the skew flap technique, which leaves an oblique scar running from the anterolateral aspect to the posterior medial aspect and retain less muscle. The different techniques can lead to different residual limb presentation in relation to the size, shape, and scar. The skew flap tend to provide an improved shape and scar at an earlier stage, but is less favored by the surgeon due to retaining less of vascularized muscles tissue and slightly more complex procedure. So again, it's surgical preference, but that's on the level of elective or semi-elective aspect. Trauma, it might be a totally different ball game. So now, residual limb length. So it's a really important factor in the prosthetic assessment. The ideal transtibial amputation is between 14 to 16 centimeters distal to the knee joint. So you need to see the knee joint and how much how many centimeters are below the knee joint. Length with fibula around 2 centimeters should be shorter than the tibia to prevent undue prominence and that can be causing more pain, especially if there are the peroneal nerve is still there and the clicking between the tibia and the fibula. We are aiming to have a large surface area to distribute the prosthetic socket pressure and have a strong residual limb to control the prosthesis and still have space underneath to fit appropriate prosthetic components. So you can see the residuum, which is the residual limb, needs to have few things mechanical that make sure this prosthetic considerations are fit within their artificial limb. The next one is talking about the residual limb shape. And if you look at the different three shapes, it's between the conical, cylindrical, and bulbous. The shape of the residual limb can have a large bearing on the prosthetic socket design, whether it's conical, cylindrical, or bulbous. A conical residuum provides a good weight-bearing surface, but can have bony prominence and other sensitive areas, especially around the nerve area, like neuromas are more exposed to the surface. Bulbous shape is one where the distal volume is larger than the proximal. This presents significant challenges for us, for all the rehab doctors, for the prosthetist, the physio, and everyone. If that bulbous, if you can see it on the C side, type C, is really challenging and it's difficult to fit into something, and it can make something called choking. Choking, it's really a crucial one that can reduce the vascularity to that limb. So it depends. This presents significant challenges for us in providing a socket that is easy to don and doff and support the residuum effectively. So in weight bearing, which is basically looking at while they are bear weight, often we will wait until this is reduced for proceeding. The cylindrical one, which is in the middle, is a nice balance between having good weight-bearing limb and protective soft tissue coverage. So we will aim for the one in the middle. So let's look at edema. So edema can have a large effect on residual limb shape. And we often see bulbous presentation in the early stage, like the first, if you can remember the case that I presented, it's about 7 days, and you can see that's how much edema and swelling. We need to wait slightly, and we need to relatively stable residual limb volume to be able to proceed with prosthetic socket, because if we make a socket to the shape of an edematous residuum, shortly after putting it on, the edema will move and the socket will no longer fit. We use a compression sock and encourage the patient to elevate their limb to help reduce any edema and provide a more stable residual limb volume before proceeding with the prosthetics fitting. And you see that it's the connection between the hospital itself and being at home, and continue the rehab with the physiotherapy and the outreach team and the occupational therapist, making sure that they are wearing the socks. Now, wound and scar is another important factor. We need to know that is healed sufficiently to tolerate the forces of wearing a prosthesis, and we are guided by the doctors and the vascular nurses. That's what always we do. We need to be guided by the team to look at the wound. The prosthetist not doesn't have that much information about the wound itself and what does it look like, is that good or not, but we work all together as a one team. So if they ask, oh, is that wound looks a little bit different from what it should be, so we can give it a look. We say, oh, this started to dehiscence, so what we need to look at, do we need to stop from wearing the limb, let the wound heal, rather than just proceeding with wearing the limb if there is a wound dehiscence or wound breaking down. So when the wound is healed sufficiently, we are looking for a flat, mobile, and supple scar. So these are the three factors you're looking at. So it will be flat, mobile, supple scar. And sometimes there can be delayed healing due to comorbidities, which can be diabetic, vascular, and sometimes there will be underlying structure that contractures or any problems with the loss of elasticity of the scar itself. So might be delaying the prosthetic wearing or prosthetic fitting, so that's fine, as long as we don't want to make it detrimental to them by not wearing the prosthesis. All of these factors make the scar less able to tolerate the shear pressure. So basically, the shear pressure, if there is a wound and there are the shearing pressure from the side, that making the wound trying to open. So if the shearing falls on the wound there and they will try to open it, so that's a problem. So we need to avoid that. So if the wound is really weak, we will wait. We will need to investigate, make sure that the wound is healed, and then we can move forward. So looking at the bone cut itself, so similarly, we are looking for the smooth edges at anterior distal tibia and lateral fibula, and good soft tissue coverage. So these are the two main things. It needs to be soft, it needs to be smooth, and good soft tissue coverage. It shouldn't be prominent under the skin directly, because that start to be making a pressure sore at the edge of the prosthesis. So these kind of amputations, if they have like a bone prominence, that will end up with a pressure sore and pressure ulcer, and the patient can't put the prosthesis in. We look at the distal redundant tissue, how much tissue redundant in the limb itself. And the condition of any distal redundant tissue is important. Some soft tissue to provide cushioning without being excessive is ideal. So you need some redundancy, but not that much. And we need to define it. If it's like a poor soft tissue cushioning or optimal, or will be excessive, and prosthetic management to stabilize, or might need a revision surgery. So if there are extra soft tissue, it's not viable to put the prosthesis on it. It can lead to movement within the socket or can migrate away from the sensitive bony prominence, exposing. Excessive redundant tissue often need to be stabilized with a prosthetic liner or even revised surgically. So things need to be changed sometimes if there are too much soft tissue there. It's not a good factor. With mentioning everything around it, still we need to make sure that the skin condition is still normal and ideal, but that's not possible, especially with the bad nutrition and with the injuries or the burn around it because of the ballistic injury, and it will end up with hypersensitivity or hypersensitive, dry, cracked, or discolored. It might be cold. All of these factors need to be adjusted, making sure that the limb itself and the skin itself not too much dry, not too much moist, and it needs to be in the middle. One of the crucial ones is having a proper knee range of motion. It's really important to make sure that we don't have contractions, and the physiotherapist, they will jump in that one and making sure, oh, we don't have that much. So assessing the joint range of motion is crucial, and the presence of the knee or hip flexion contracture can have a large impact on the position of prosthetic sockets and can prevent them from wearing it. This can compromise the knee flexion in setting. The aesthetic appearance of the prosthesis, the weight of the prosthesis, and the component selection, as well as providing manufacturing challenging. And you can see the example on the picture. So you can see if it's really flexed like around 15 degrees, like you have like range of around maybe 5 degrees or less. You try to avoid any contractures, because the socket itself, it will be bended backward, and that will be really challenging to put it on, and the patient will be mobilized with that kind of prosthesis. I know prosthetists will try to adjust it, will say we can do it, but don't forget about the soft tissue and the limb itself. Patient weight. So patient weight is really important to know, and how much weight of the patient and the amputee they have. We always record the patient weight to monitor trend that may affect residual limb volume or explain residual volume that changes, but also ensure they provide the prosthesis suitable for their weight. Okay, and this is related to the manufacturing. You can see that an example, suitable weight rated prosthetic components is around 226 kilograms max, and we need to make sure the risk, it's not only about the components, it's about the weight itself and also the energy of the patient. Prosthetists, they have different management options for the socket design, because they are patella tendon bearing or total contact. Basically, there will be the kneecap itself. So the weight bearing, it will be a flange, and they will be under the kneecap, and that's called patella tendon bearing, or PTB. Or there will be the total contact. Basically, it will be all around the residuum itself, and that will be holding it. The suspension method, we will discuss about the suspension method, will be cuff, and there will be either the cuff, it will be the sleeve, There will be suction line. These are the materials they are using it to help them with the donning and doffing, so removing and putting. The interface is the socks. So you're putting the socks in, and then you put the prosthesis, and that will be the silicone gel. It's different material that can be used in the interface, and depends on the skin and the soft tissue itself. There are different manufacturing techniques and there are the material selections, but these are basically what you are looking. You're looking at the socket, the suspension, and the interface. These are the three elements that you are looking at: socket, suspension, interface. If you understand these three elements, everything after will be easy. The whole process is multifaceted. Each choice will have an effect on another aspect of the prosthesis, and this all needs to be considered and discussed with the patient to find most acceptable solution at the point in time. For example, it may be beneficial to use silicone liner, or for one reason or another, which can be really helpful for neuropathic pain. Maybe to improve cushioning in the socket, but that could lead to the prosthesis becoming more bulky because it's really thick, the silicone one. So all it depends on the factors of the patient. Finally, we use this type of score, which is the Chakrabarty score. It's a scoring system which rates these different aspects, what we all discuss, of amputation, and give the score out of 100. The higher the score, the better that help predict prognosis, complications, usage, and can also use as an audit tool and to help with feedback to the surgeons. So to manage that, what we expected, which is we will use with you guys for assessing, when you're assessing the patient, seeing and then ticking the boxes saying, oh, this is what we need to look at. And what are the problems we have in our cohort of patients for the traumatic and ballistic injuries. And that's it. Thank you very much.